Good morning, everybody. Welcome to this Health Foundation webinar on the hot topic of what does the future look like for general practice workforce. I'm Jennifer Dixon, and I'm really pleased to be your chair for the discussion today. It is a fittingly hot topic today. Workforce shortages are the big single challenge facing the NHS and adult social care, as we know. And recently published projections from the Health Foundation's Real Centre show that the shortage of GPs and general practice nurses is set to get substantially worse over the coming decade. And without a change to current trends and policies, more than 1 in 4 GP and general practice nursing posts will be vacant, and there'll be a shortage by 2030 to 2031 if we are to continue with the levels of care that we're providing at the moment. So it's a really squeaky hot issue and very fitting for our webinar. So we'll be discussing today what's the outlook for the supply of and demand for GPs and other clinical staff working in general practices and primary care networks. What are the implications for the future of general practice over the next decade? And what are the solutions we need? So with us today to discuss all this, I've got a very terrific panel. So first off, we have Anita Charlesworth, who is the Director of Research and the Real Centre, which is research and economic analysis for the long term at the Health Foundation. She is an economist, but she does many other things, and very well, I might add. We are joined by Rebecca, or Bex Fisher, who is a Senior Policy Fellow here at the Foundation. And Bex leads all our work on primary care and general practice, and she's got a particular interest in equity of access to primary care. She's also a practicing doctor and works for 2 days a week as a GP in an area of urban high deprivation in Oxford. And then Matthew Taylor, who's Chief Executive of the NHS Confederation, which he joined in June 2021. Now, Matthew is known to many of you. He led the RSA, the Royal Society of Arts, for 15 years. Before that was Chief Advisor on political strategy to the Prime Minister, Tony Blair, and he's also headed up IPPR. He's well known on TV and radio, and he's also a regular on BBC Radio 4's Moral Maze, where he's on this evening to talk about the NHS, and actually I'm joining him, so please chip in, have a look at that. It's on Radio 4 at 8 p.m. So today we've got just over an hour. Anita is going to present some killer facts for us over 15 to 20 minutes. Bex and Matthew will then respond. We'll have a brief discussion and then turn to the audience question and answers. And we'll wrap up by 11:15. Your questions, please use the Q&A box at the bottom of your screen. Ask the questions, upvote the ones you like, and I'll then know which ones are the most popular, and I'll get to those, as many as I can. And for those of you who have submitted, thank you very much. I've got those questions, and I'll turn to some of those as well. For anyone wishing to tweet, please use today's hashtag, which is hashtag NHS Workforce, to continue the conversation. And just to let you know, we are recording, and the recording will be on our website within 24 hours, so you can watch again or tell your friends. So with all of that, I'm going to kick off now and ask Anita to go for it. Thank you, Anita.
Hello, everybody. I always hate that moment when you have to screen share. Yeah. So what I'm going to talk about today is to go through our projections of the position for general practice in England. And it is only England that I'm looking at in these figures. And it's general practice, not GPs alone, that we're looking at in this analysis. And I'll emphasize that point because I think what perhaps still is not well understood by the public, or dare I say policymakers, is just the diversity of the workforce in general practice today. So this chart shows the proportion of people working in general practice comparing December each year from 2017 up to 2021, and it looks at the share of different staff groups. And as you'll see, back in 2017, 27% of those working in general practice were GPs. By December 2021, it is down to 24%. So actually GPs are a minority of the staff in general practice. Around half of the staff in general practice are involved in direct patient care. And then there's half of the staff who are in administrative and non-clinical roles. In direct patient care, what we've seen is, so the red bar, as I talked about, is GPs. The green bar is nurses. Obviously, we've had nurses in general practice for a long time. Back in 2017, 13% of the general practice workforce were nurses. That again has fallen by December 2021 to 11%. And we've seen a doubling over just this 4-year period in the proportion of general practice staff who are from other clinical backgrounds. So obviously this is a big direction of policy in relation to general practice, out of long-term plan, other changes. Who are those people? Well, obviously, two biggest groups are pharmacists and physiotherapists. Then we've got the new roles like social prescribers that people may be very familiar with, but also things like paramedics coming into general practice as well. So the figures that I'm going to talk about today are those half of the general practice workforce who are providing direct patient care. So that's the GPs, the nurses, and that wider staff group that now makes up 16% of the workforce. I'm not going to look at the 49% who are in administrative and non-clinical roles, but I would make the point that that is quite a lot of people and an enormously under-researched area, and we don't really understand very much who those staff are, how we ensure that we use their skills as well as possible, and it's a big and important workforce. So the way I'm going to look at this is to compare workforce demand and workforce supply, and the gap between the two is either the shortfall or the surplus. In the health service, I don't often get to show a surplus. It's normally about the scale of the shortfall that we're looking at. In terms of demand, the way we look at that is that we look at the amount of activity that we're expecting to provide. And we think about that in a number of ways. We take a kind of model of care. In our case, we think about the services pre-COVID. We look at how demographics, more people, age structure of the population is likely to increase demand. We look at morbidity trends, how the health of that population is likely to affect demand. That's the underlying trend, but then obviously we have policy on top of that, and we have policy objectives to increase the role of general practice within the NHS. So we look at those additional demand pressures as well. That gives us demand. We then look at workforce supply, and as I said, I'm going to look at that in relation to recruitment and retention for three groups: GPs, nurses, and other direct patient care staff. And the gap between the two is the gap, it is the shortfall. And we think about this because obviously we're looking forward, we're projecting. So we're exploring what this might be, looking at three different scenarios. Really important to say, this is not what we think should happen. This is not what we think will happen, definitely. These are projections. If this, then that, yeah? So what are the factors that influence supply in our scenarios? So we look at the numbers of people in terms of GPs who are joining. We'll look at the leavers, and the leavers we split into two important areas: those who are expecting to retire, and we'll look at age 55 plus for that, and those people who are leaving before the age of 55. We'll look at international recruitment, and we look in relation to GPs at the effect of multidisciplinary teams. So are we seeing that some staff groups are taking some work off of GPs? For nurses as well, we'll look at leavers, the same retirements and before, and we look at the joiners and international recruitment. It's worth saying that international recruitment for nursing is really important for acute sector nurses. There's actually very little direct international recruitment into primary care, into general practice nursing. So what's international recruitment is a really big part of the story of the overall supply of nurses for when we look at the NHS as a whole. It's not such a big issue for general practice. And our scenarios are: what happens if we stick with current policy, we stick with current trends? What happens actually if we can get a bit better? This is our optimistic scenario on things like the leaver rates, so fewer people leaving, more people joining. And what happens if we're a bit more pessimistic? We'll look at some of the things that have happened in COVID through things like leaver rates, and continue those on. Yeah, and this is to explore the contribution of those different factors. Oh, sorry. So the first thing that's really important to say, I think, here is that a lot of the debate about the workforce says we've got more staff now than we've ever had, and we're going to have more in the future, ergo there's no problem. And we do have more staff now than we've ever had in the NHS, and we are going to have more staff in the future. The question is not, have we got more, but are the increases in staffing commensurate with the increase in demand? And so often policy dialogue operates on the basis of the sort of almost implicit assumption that demand is static, that if we could just, what we need to do is to continue with what we've got at the moment. And what you see when we project forward the growing population, the aging of the population, morbidity, is we see that we expect demand for general practice services to increase by about 20% by the end of this decade. And that's not really surprising when you think that the numbers over 85 through this period are growing by a third, that the number of people at the end of life through this period are growing again by about a fifth. So it seems pretty realistic to think that the demand coming through the door of a general practice is going to increase by about a fifth. And that's true for the demand for GP services and for practice nurse services. We come into this period where demand is increasing with an existing shortfall. So we look here at demand and supply, and at the moment, and by the moment I mean the 2021-22, ideally we'd have, well, not even ideally, you know, in order to not have significant problems, we'd have 31,300 GPs. And here I'm talking about qualified permanent GPs, and we've got 27,000. So the current shortfall is about 4,200. You will then see that when we look at 23-24, which is sort of the end of this parliament, what we're projecting under all scenarios is that the shortfall in GPs will increase, and will increase significantly, from 4,200 to 7,300 shortfall in current policy, could be as bad as almost 10,000 GPs. So in the short term, things which are already incredibly challenging look like they're going to get quite materially worse. The question then comes, can they then get better? So we've got here out to 2030-31 are three different scenarios. So the red bar is current policy, and obviously in 2021, under all three of our scenarios, the red, teal and purple, the situation in 2021 is the same, that shortfall of 4,200 GPs. By 23-24, that grows from anywhere between 7,300 and 9,700 shortfall, so it gets materially worse. By 2030-31, under current policy and trends, that rises to a shortfall of 10,700. So that's the 1 in 4 figure that Jennifer mentioned at the beginning. So under current trends with demand, we would be short 1 in 4 GPs. If we could improve recruitment and retention, ensure that all these new roles are well absorbed into general practice and expanded, we don't eliminate the shortfall, we still have a shortfall, but it does reduce from the current shortfall down to about 3,300. Actually, if some of the worrying trends that we've seen in terms of early retirement, pre-retirement leavers were to continue and escalate through this period, things could be as bad in our pessimistic scenario, where we were in a position where half of all GP posts were not filled and the shortfall was more than 20,000 GPs. I think both 1 in 4 or 1 in 2 are pretty existential issue, and 2030, 31 is not very far away when you think about how long it takes to train. Position in nursing is rising demand for nursing, that's my yellow line. And again, in all three of the scenarios we have for nursing, we're not able to meet demand. In nursing, retirement is a very big issue. So 40% of practice nurses are age 55 or above. So we've got an aging workforce, and for too many years, we've not been attracting younger nurses into general practice. And I think that's something that we really need to look at. On direct patient care staff, so that's those wider roles that I was talking about, like physios, pharmacists, social prescribers, paramedics, it's much more uncertain where this might go. We're obviously in the middle at the moment of a major expansion in this workforce. Quite where that could go is unclear, but I think one of the things that we might talk about here is just what is the potential, because over this decade, it really doesn't look like we're going to be able to meet the demand for general practice services through a GP and nurse model. We are going to have to diversify the workforce further if we're to be able to cope. So the position that we've got at the moment is that under all of our scenarios, the supply of GPs and practice nurses is likely to fall short of demand and fall significantly short of demand. Central projection with current policy is about 1 in 4 posts unfilled. That obviously, shortages of that level raise serious questions about patient safety, quality of care, equity of access. They also raise really important questions about the whole vision that we have with integrated care systems for an NHS which is increasingly looking at earlier detection, more prevention, more care in community-based, home-based settings. So this is a really important issue for general practice services, but it's a really important issue as well for the wider vision for the NHS. Incredibly important that we have sustained policy action to improve the retention of GPs. Also, we're saying today we've published figures generally on nursing, and obviously the government has got its target for 50,000 nurses overall. At the moment, there's a lot of policy action to try to improve and tackle shortages of nursing in the acute sector. But there is really no strategy that I can discern for general practice nursing and how we're going to ensure a pipeline of nurses into general practice, given the ageing of that workforce. And that's really, really critical. It's not enough just to simply have these aggregate targets for a staff group as a whole. We need to worry about where in the country people are working. That's really important, again, here for general practice and nursing, because these shortages are felt most acutely in more disadvantaged and deprived areas. The key to success looks to be obviously to do everything that we can to keep people and attract people. But actually our analysis would suggest that this widening of the primary care team and the effective assimilation of these new roles into general practice is going to be really, really important over this next decade. Thank you. I'll stop sharing.
Great, thank you so much, Anita. Lots of questions already. We'll get to some of those, but just a couple of quick ones that people have asked about the modelling. What assumptions have you made in your modelling about social care?
So we don't explicitly make any assumptions about social care. I think it's fair to say, though, there is some new data out today from Skills for Care showing worrying reductions in the social care workforce, lack of social care provision, and that can only add to the pressure and demands on general practice. We've also got issues in terms of NHS community services and pressures there as well. All of that, and also I guess, you know, it is the case as an interconnected system. So the other thing, obviously, GPs are also saying is, while we've got real issues about hospital access, long waits, a lot of time what they're seeing now is additional demand as people coming back to them, assuming that general practice can sort that out and help them. So the squeeze on all parts of the rest of the system will increase demand pressures in the NHS. We haven't modelled that in. That would make that demand pressure even greater than the 20% I talked about.
Thank you. And one other thing, which is, I suppose we're getting into solution space, but somebody has asked a question, which is there's more demand for nurse places than there is supply. Why don't we just increase the number of places?
Extremely good question. And I agree. I think one of the issues that we've got is that we've been struck. Well, one, there's funding, and government has got prepared to fund it. That's important. Secondly, though, universities and the NHS for clinical placements have got to have capacity. So if we do want to expand more, I think there's a really strong case for expanding nurse training more. We've got to look at the same time also at the model of nurse training to make that as efficient as possible, so that we can effectively expand, and we can expand and give people a quality experience. One of the problems over the last couple of years that people are worried about is we have expanded quite a bit. So we're now, through COVID, we're at 29,000, I think it is, people starting nurse training this year. But if we give them a bad experience of nurse training, we'll see high attrition. So you've got to be able to make sure that this all works, that we get the numbers in, that the experience and the quality of the training is really good, so that they don't drop out.
Yes, thank you so much, Anita. Right, so we've had the angel of death figures here from Anita as people. We normally ask her to wear black with presentations like this. Bex, lots of things to pick up. So let's hear from you on your response to those figures. Thank you.
Thanks, Jennifer. And I am wearing black, which wasn't an instruction. But look, it's absolutely grim, isn't it? I've been working in general practice for almost 10 years now. And I think there will be lots of people listening to this, watching this webinar, who are GPs and work in general practice more broadly. And the pressure is unbelievable. We've been waiting for years for the cavalry to come, and the cavalry aren't coming. And I think the first thing to say is that is not chance. That is a reflection of a long-term failure of workforce planning and policy. I also think it's really important, and Anita made this point briefly in closing, to understand that these are projections across the workforce in England, but they're not about the distribution of the workforce. And the distribution of the workforce is so vital as well. General practice in our most deprived areas is underdoctored. We're starting to talk about general practice deserts. Those are really depressing conversations, and there's clearly a risk of that becoming much worse, with real knock-on implications for the kind of ability of the health system to do anything meaningful on tackling health inequalities. We just kind of zoom out a second and say, well, is this level of GP and general practice nursing shortage a problem for our health system? Absolutely yes. There is so much evidence that suggests that strong primary care is the foundation of health systems with better health outcomes and that are more cost effective. So I don't think the question that falls out of kind of quite grim projections like this is primary care the right model? But I think that it is. But I think that the conversation about how we deliver primary care has to start changing. We have to talk much more realistically about how we deliver high quality general practice in the context of ongoing GP shortages. And I think we'll get much more to that in our panel discussion, but I guess just a couple of quick thoughts. The first, this is really obvious, but just back to my first point, we have to have a comprehensive workforce plan for general practice. We have to have a plan that is properly funded and that takes into account the distribution of staff to make it more equitable, but also the distribution of staff between primary and secondary care. We also, as Anita has said, have to think really carefully about the skills mix of staff. So how do we integrate those roles effectively, efficiently? But I think there's a big implementation piece in that. General practice is often operating in small units. We're not set up for massive transformation programs in the same way that acute trusts are. And this is in effect a massive transformation program in the NHS, 26,000 extra staff in general practice. So how do we do that? We can't just say we want them to be efficient and effective. We have to work out how we support general practice to do that. There'll be a role for technology, of course, and digital, not just in helping people access general practice, but in helping us become more efficient. And just the retention piece that Anita talked about, I think is so key. We know that GPs at all stages in their careers are quitting or considering reducing their hours. I think there might be some quick wins on things like pensions cap, but actually there's some really difficult stuff in here. And I think that really difficult stuff is about job satisfaction. And all the evidence at the moment suggests that the key factor in job satisfaction for GPs is excessive workload. And that is really hard, because how do we reduce workload in the context of projections like this? I think it brings us to some quite, I mean, frankly, for me, existentially uncomfortable questions as a GP about how we cap workload. Do I start really rigorously saying, well, I'm actually only going to see 40 patients in a day because that is a safe limit? It's a very difficult thing to do, but I think it's a really important question. And crucially, and the final thing I'll say, is that I think that involves a very difficult conversation with the public about what general practice looks like. Part of that conversation is about, we're saying we're going to have different skills mix in general practice, different roles. It may feel a bit different when you access general practice, but we can still deliver high quality care. But part of it is also being realistic about what needs to come to general practice and what doesn't. And I think in the context of the new Prime Minister, it's really vital that politicians are reasonable and level with the public about what they can expect and demand from general practice. And I think there is a very real risk that if that message goes wrong, that we will further demoralise general practice staff, and we will make the problems that Anita has just so clearly articulated even worse.
Thanks so much, Bex. I mean, the public at the moment, the last GP survey I saw with a patient reporting what they felt about general practice, 2/3 were satisfied with the quality of care given. And that has reduced from 72% to 2/3, so a little bit of a drop, but not much. Against that, the British Social Attitude Survey did show a dip in overall satisfaction with the NHS. So there's a slight deterioration. We get on to long-term solutions, I think, in the major discussion. But just for you on the short term, all of these dials turning red must be absolutely loud and clear to policymakers, particularly at NHS England level. Can you say anything about the short-term plugs that they have sort of been trying? What's effective, what isn't? What kinds of things have they been trying to encourage numbers up or reduce attrition?
Yeah, I think let's separate that out, because there's more success in the first part of that than in the second. So the number of GP trainees is at its highest ever level, right, which is good. So there are more coming through the pipeline. Yeah. There is, I think, much more that could be done. So all the evidence on GP recruitment suggests that actually this is a battle that needs to begin in medical school, possibly even pre-medical school. It's partly about perception. When I was at medical school back in the dark days now, you spend a vast amount of your time practicing in hospitals and a very small proportion of your time in general practice. That probably has to change, because we know that ultimately, if we want the pipeline into general practice to expand, we have to begin that in medical school. And there is also, again, this is hard, I think, as a doctor to look inwards all of the time, but there is a lot of cultural stuff within the profession about, do you want to be a GP? Do you want to be a hospital specialist? There is a negative perception of general practice, and that will have to shift. It cannot be second best. So there is more that we can do on recruitment, but that's where progress is being made. The pipeline is wider. The attrition is going to be, and the retention, I think, are the really key things. And yeah, honestly, there has been a struggle. There have been some small, fairly small in the context schemes, things like a retainer scheme to help GPs who are considering leaving, that are certainly benefiting a small number of GPs, but it's small in the overall context of the workload challenge. And that's, I think, why I was trying to articulate it as the big thing. I think survey after survey is so clear on this at the moment. Workload is the challenge, and workload is the biggest arbiter of job satisfaction. One last point. There are, I think, probably some mutual wins here for the service and for patients. So something that we hear, actually, we partner with the Commonwealth Fund at the Foundation on an international survey of GPs. And we see time after time in that our GPs in the UK have the shortest consultation time, yeah, and are the least satisfied with the duration of their consultations. We know that patients want longer consultations. So I think there are some wins here where we can probably get increased job satisfaction for GPs as well, but we can't have longer and longer consultations with fewer and fewer GPs and more demand. So we still have to solve some tricky problems.
Yeah, sorry, can I just sneak in an extra because it's relevant here? The move to virtual that we saw in the pandemic, is that helping or hindering GP workload or satisfaction?
So we don't know is the frank answer to that. We sort of pivoted overnight because we had to, and didn't have robust evaluation infrastructure. And the answer to that will almost certainly be a mix. There are big concerns where equity is concerned, who is not getting in. And I think, and this is completely anecdotal, Jennifer, my experience is that some people love consulting like this. Other people really don't. I personally, we were always open, but we did see fewer people face to face. I really miss that. I love seeing people face to face. And so I think there's a bit of the pendulum swung too far one way in the pandemic out of necessity. Now we need to work out where the right level is, and it will be different for different patient populations and different practitioners.
Yeah, it'd be interesting to see if there's a cohort effect, an age effect with younger GPs. How do they feel about virtual compared to GPs used to a different type of practice? But we'll maybe get back to that. It'd be interesting to have people commenting on that in the chat. Lots of questions. We'll get to them in a second, I promise you. Matthew, your view, sort of almost standing back from all of this, on what you've heard, particularly on the issues, but also how far are we tackling the solutions, and do we need to do something different to really grasp and make progress here?
Thanks, Jennifer. Yeah, I tweeted that we were on moral maze tonight, and I tweeted that I've come to realise over 15 years on the programme, the more you know about a subject, the less well you perform. But it's fine, because someone said to me, don't worry, we'll all be watching the Lionesses play in the Euros anyway, so no one will be listening. So we can relax, Jennifer. Well, look, the first thing I want to say is thank you for doing this work. The phrase that we're using, particularly at the moment in the Confed, is the need for a realism reset. One of my favourite quotes is from the American author James Baldwin, who said something like, people can cope with almost anything once they know where reality is. And the problem at the moment, when we talk about the health service, is often we are dealing with kind of mythologies, whether it's 14 new hospitals or 6,000 more GPs, or social care is assorted, or the NHS is awash with money, when actually the NHS is experiencing its first real terms cut in funding for decades. So it's really important to have a realism reset, not in order that we can indulge in misery, but you just can't address a problem properly if you're not starting from where the reality is. So Anita, Jennifer, this is vital work, and we're very grateful for you for doing it. I also think it's important to say that, as Anita has said, that things will get worse, and as Bex in a sense has said as well, things will get worse on current trajectories, because there's a kind of death spiral here, which is we don't have enough people in primary care, the demand gets greater, the workload gets greater, public satisfaction declines, the job becomes even less attractive, and so we go on. And one's also aware of the kind of problems in a complex system, of the fact that decisions made in one part of the system have ramifications for others. So yesterday's pay awards, there's the issue, of course, of the fact they're not funded, and I might mention that later, but also, of course, that will increase the gap between the wages on offer in the acute sector, for example, and the wages on offer in primary care. So, actually an exacerbated situation as a consequence of the decision yesterday. I don't know where anybody can have thought that through. Perhaps there wasn't much that could be done about it, given the GP contract deal, as it were. But things happen which make this even more challenging. So what can we do about it? Well, I think I'd focus on two things, really. The first is that we need to continue to encourage, not force, but encourage primary care to grow at scale, to become a more at scale operation. I think that when We work effectively through primary care networks, through federations, and I think probably through neighborhoods is where we're going. That offers things which, you know, don't inherently make the situation better, but offer opportunities to improve the situation. So they offer opportunities for career development. So if you're working in primary care at scale, there are opportunities to take on management and leadership roles and more specialist roles within that broader team. And I think that's important. Productivity gains, of course, you know, prosaically in kind of back office, but potentially in relation to multidisciplinary teams and thinking about different kind of models of care. Thirdly, I think it's only at working at scale that you can really start to think about population health management and prevention. And that's what, you know, we need to do. We are doing some work at the Confed at the moment, just thinking about how we can close the kind of demand management feedback loop, because, you know, when we talk about prevention, often feels like it'll be in 10 or 20 years that we see the benefits. Well, that's fine, but in policy terms, that's pointless, and politicians aren't interested in 10, 20-year feedback loops. So what can we do in the kind of area of secondary prevention, although people define secondary prevention in different ways? What can we do to do better to kind of demand management? And I think, again, things like that, things about really engaging with population health data and thinking about prevention, demand management, being more proactive, I think all of that is more possible at scale. Fully exploiting the new roles that we've got, I think, again, that's an opportunity that is more present at scale. And finally, working with systems. That, you know, what I'm going to come on to, my third point is really going to be about system working. And I think for primary care to be a system player, it requires primary care to be working at scale, to have that kind of voice. So that then takes me to my final point, which is about system working. So I think this is also absolutely critical. We have to see the future of primary care as not a primary care problem, but as a system challenge. And that's why we welcome the work that Claire Fuller did. And not only in terms of the content of that work, but also the work that Claire did to get every single ICS to sign up to her vision. I thought that was a really important way of doing things. In my Confed Expo speech a few weeks ago, still available on YouTube, I argued for the Fuller principle, which is that NHSA should not require systems to undertake significant changes without trying to get them to sign up to that. Because if ICSs aren't signed up to it, well then, you know, why not? And it's unlikely to work. So I think both the ideas that Claire developed and the way she worked with systems is to be commended. And what we need is primary care to have a seat at the table when we think about system challenges. So, you know, forefront of people's minds right now, let me take two issues: urgent emergency care pathway on the one hand, and preparing for winter on the other. And it's absolutely vital that primary care is at the heart of reimagining the urgent emergency care pathway, as Claire Fuller argues. I worry a little bit that UEC work at the moment is too acute focused, and I think it really needs to be focused on the whole system. I mean, that's part of a more general kind of challenge about NHSE tending to be slightly acute focused. Or think about winter. You know, there is ICS is already under. It seems bizarre given that we are just coming out of a heat wave, but there is a lot of absolutely justifiable concern about what winter is going to be like. And it's really important, again, that primary care is involved right at the beginning of that conversation. What can we do differently this winter, whether it's around prevention or whether it's around public engagement? And that's part of, and I'll finish with these two very brief points. That's part of what we have to do, it seems to me, at the moment, is practice what I call split screen thinking, which is we've got to think about how we address these immediate challenges in this screen in ways that are informed by the vision we've got of the long term. Because if we don't do that, we'll just be caught in the NHS trap, which is saying, well, look, in the long term, we want to move resources upstream from acute. In the long term, we want to move from meeting demand to meeting need. You know, in the long term, we want to move to incentivizing outcomes, not activities. But, you know, we haven't got time to do that because we've got vaccination program, we've got winter, we've got this, we've got that. We've got to start trying to address these short-term problems with the vision of where we want to get to ultimately. And then my final point is this. I also think that when we address the future of primary care, we need to move, and this is a more general point about the way the NHS is structured, we need to move the accountability focus. So I think if we can move to more to primary care being part of integrated neighbourhood teams. The opportunity there is to move from this unbelievable level of control and micromanagement over specification, which comes through the centre, down to the centre, through the GP contract and revisions to GP contract, to something which is really about identifying at system level and at place level broad outcomes, and then working with primary care to think about how to deliver those outcomes, and where the accountability is much more lateral. Accountability so that primary care, in a world which can be awash with data, when we look at what primary care is achieving and we focus ultimately on population health outcomes, the accountability of primary care is to community, is to social care, is to voluntary sector, is to community, patients, citizens, rather than, as we always do in the health service, we spend so much time looking up and responding to centrally defined specifications. But it'd be much better if we looked out to that broader team of people, many of whom are spending most of their resource on exactly the same patient group, in social care, in community, in primary care, the voluntary sector where they put their resources, the same patient group. And surely we can come up with better, more locally based solutions. And so I think that's the other thing, is let's strengthen the accountability primary care has outwards and downwards, and loosen the accountability that it has upwards.
I mean, just thinking back to big problems that the NHS has faced and actually solved. I'm just thinking way back to when you were probably knocking around for Prime Minister's office in 98, 99, maybe. I think that was your time, was it?
I was a bit later.
A bit later. So there was a massive, obviously, waiting lists were the big issues. All the, never lists, people languishing, people dying, Jennifer's Ear, all these cases, Sharon Stoner, Jennifer's Ear, Mavis Skeet. I remember these cases really well. There was then a big push to get waiting lists down. It was very top down. There's lots of money invested. But what you're saying, and in fact, there's a question here from James Morrow about this, is that this issue about primary care, as you say, is much more complicated than that. There's more issues. It's not as simple as getting waiting lists down, even though that is complicated as well. What kind of new type of, given that, what kind of, do we need a new approach to solutioning that involves practitioners far more than we have in the past to try to solve some of these problems, even if some of them need a national response? What's the policy making sort of approach that we need now on this issue that may be different to one that we've used in the past, which has been relatively simple, I would say?
Did you say Sharon Stone in that list, Jennifer? I'm completely confused. You did, I think. I don't know what the element of what recollection you've got there, but anyway, I'm moving swiftly on.
I'll check that. I thought I'll check that. The word stoner is in my mind, but maybe that is a figment of the heat. But certainly Mavis Skeet, let's put it that way.
Yes, okay. No, I mean, I've missed that specific bit of primary care history, but I'll look into it. Yeah, I mean, and in a way, that's what I was kind of referring to.
Yeah.
At the end there, which is, I'm not a health expert, as may be becoming clear to the audience, but I've been doing the job for a year and I'm on a learning curve. And yeah, but I have got a kind of broader background of thinking about policy and change. And the one really kind of simple, very broad conclusion that I came to doing all that work is that change is most likely to succeed, and organizations are most likely to thrive, policy is most likely to work when you can articulate and balance three sets of drivers for change. So the top-down drivers, and top-down drivers are important in terms of accountability and strategy and priority. And then lateral drivers, which are to do with kind of leader to leader, clinician to clinician. I was talking about, integrated neighborhood teams, that kind of culture of challenge and support. And then bottom-up drivers, which is responding to citizens, patients, customers, consumers. And systems that manage to articulate and balance these three sets of drivers, they become really dynamic. Right. And the fundamental problem of the NHS is that we just spend far too much of our time looking up. And that means we're not dynamic. we're constantly responding to what comes down from the centre, and it's exhausting, and it inevitably leads to all sorts of kind of perverse incentives and gaming, and it's just inevitable. That's how the world works. So that's the first thing we need to do, is to recognise that and to encourage a centre to focus more on incentivizing outcomes and having broad objectives, and yes, using data so that we can hold ourselves to accountable, but to actually liberate systems, places, neighborhoods to develop their own approaches. And obviously now we are in a world where we're going to emphasize collaboration, we're going to emphasize integration, and we need to push ahead with that. And we do need to see 1,000 flowers blooming. We do need to see a lot more experimentation. There are really exciting examples, as you know, of great practice out there in primary care. Of people, despite the pressures, doing really good work thinking about population health. Very different kinds of models, really exciting models, the kind of models that I think would encourage even more people to want to become GPs or stay as GPs.
Yeah.
But they've developed those models not as a consequence of top-down incentives. They've developed as a consequence, and I speak to the leaders involved in that, of their close relationship to their community and their frustration about not engaging fully with their community and their desire to do things differently.
Yeah, and just to follow up, and maybe others can maybe contribute. How far do you think then that we should move away from a national GP contract towards something more regional to allow more flex?
I always think that the more we can specify things in terms of outcomes rather than inputs and outputs, the better. So I think that what we want is there will be a GP contract framework, but the more that is based upon population health outcomes, and the more then it leaves space within that at system, place, and neighbourhood level to think about how those outcomes are going to be achieved, the better it will be.
Yeah.
So I don't think we'll ever get rid of of having a contract, but I think it can be a outcome-focused contract which allows more space for innovation and collaboration at a local level. Because the problem, of course, is one of the problems of these kind of top-down systems is they make collaboration much more difficult.
Yeah.
Because instead of being able to kind of work together, people say, well, the problem is I've got this incentive and this target, and my income depends upon it. So I'd love to be able to help you, but I don't have the latitude to do so.
The thing about outcome, I mean, I just did some work, I think it was for Jeremy Hunt, dare I say, a few years ago on GP outcomes, and the issue there, the GPs were saying to me that actually you can't ask us to, well, they didn't use these words, but outcomes are very difficult to ascribe to general practice versus other parts of the system. So it's very difficult to hold practices to account for that. It's the whole system, and once you have accountability across the whole system, then accountability is diffuse. No one owns it, if you see what I mean. So I'd be interested, Bex, in your view on that, considering that you are at the sharp end here. But I remember the GPs being very firm about that. They felt that they were only responsible for some things, and some things actually looked quite processy and not outcomey.
I think it's a particular challenge, Jennifer, in the context of the conversation we're having today as well. And there is a real risk that general practice and primary care more broadly is becoming a bucket that an awful lot of stuff gets talked in. And I think one of the conversations, we're sort of having two parallel conversations. One is about potentially really massive, significant workforce shortages in an absolutely critical sector. And the other is about how you expand the role of the sector. And those conversations do need to coexist, but I think we also have to acknowledge the inherent tensions within them. To come back to the kind of contracting, because contracting and accountability are in some ways, I think, intrinsically linked. The local national, there is a very understandable, I think, and this is a personal view, have a lot of sympathy for the local ownership. We know what we need for the care of our populations. A real strength of general practice is how closely entwined it is with its neighbourhoods. But my personal view is that there are some elements of GP contracting that need to be done at a national level. It takes a huge amount of skill and expertise to negotiate a contract. Some ICS areas will probably have that, but I would be worried about supposing that all of them do. So I think for me, an ideal situation is you have a nationally retained GP contract, but with probably more local flexibility. I would separate that out, and I can see lots of questions in the chat about partnership and things like that, and we may get onto that. But I guess I would also just suggest that there are another couple of parallel conversations I think about. What is your operating model of general practice, and then what is the business model that can support that? And again, they are two interlinked questions, but they are, I think, discrete.
Yeah, thank you. Anita, I think you wanted to come in.
Yeah, I wanted to say a bit, because there are different staff groups going on here. So there's the GP contract, which both obviously is a way in which GPs themselves earn their income, but it also covers the expenses of the practice through which they employ and remunerate staff. And one of the questions we've got as this service is becoming more complex with the wider staff group is to think through, I think, whether that staffing, that direct employment model for all of those wider staff is the right way to go. Because obviously, if a nurse moves from an acute hospital to general practice, they lose the agenda for change.
Yeah.
And that's I mean, that's quite a big issue, and general practice is going to have to work out what to do in response to this pay award. So that is quite an issue. One other thing, lots of questions in the chat about the detail of the in the Q&A about the detail of the modelling. We've put the report, the link to the report, in the chat. Please do have a look at that. I think and hope it answers all your questions.
Right. Bex, did you have a response you wanted to make then, or not?
It was just a very quick point on the contract, and thinking about the short term, to 23, 24 in the context of pay. I think we are on a sticky wicket with the current general practice contract and the pay. So the 2019 contract was a 5-year contract. So there was no adjustment for inflation baked into that, and there was no adjustment for the increased demand of COVID. And so if we think about the projection, the assumptions that we made for the modeling in the projection of this, it brings me back to that more, I am feeling more pessimistic about some of them. I don't know how others watching this will feel as well. But if we think about the contract we have now and the situation we are working with, there is a discrepancy. And I think that will impact adversely on our retention, and it will increase attrition.
Right.
Jen, if I can just come back to your point about outcomes. I mean, two things. One is, data really is changing things. So the quality of data, the speed of data. So our capacity, I think, to have a pretty granular understanding of differences in different outcomes, and to identify things which really, need looking at more closely. And also, you talked about different change models, and one of the most successful public service reform programs of the last 25 years was London Challenge, and which really kind of transformed the outcomes in schools in central inner London. And one of the clever things they did there was they put schools together, had very similar catchment areas, but quite different kind of levels of performance. And they encouraged them to work together as a group, recognizing they all had strengths. And the kind of idea was that you've all got strengths, you've all got very similar kinds of kids. How can you all become as good as each of you? You're all good at something. So how can everybody become as good as the best school in whatever it's good at? And I think that it would be great, be a really interesting piece of work. We'd love to do it in the Confed, for example, would be to get together, primary care in places that look very similar, where there are, good practices occurring, and bring together that kind of peer-to-peer pressure and sort of challenge and support. So what can we learn from each other? So I think you're absolutely right. The model of change that we can adopt, we can be much more imaginative than I think we have in the past.
Yeah, thank you. So there were a few questions about admin, and I think, Anita, your graph at the top, I was quite surprised at the proportion of 49% of admin staff. And admin is a friction that really irritates GPs, doesn't it? That sometimes things break down, they have to do stuff. So there was a question in the chat about, if we're talking about automating some aspects of clinical care through virtual and all that, and we'll get on to that, could we not do the same for that group of staff too? What's the scope for automation in general practice? I think, just to point, the study we did, we funded, showed that 40% of admin tasks in general practice could be automated right now with technology we have today that weren't. So, Anita.
Yeah, I mean, I think like most people then, based on the Q&A coming into this webinar, I was surprised at those figures, and they're much higher than the rest of the NHS. Partly, of course, that's general practice picking up the consequences of huge amounts of efficiency in the rest of the NHS, with the amount of paperwork that heads their way, the amount of coordination tasks that seem to head back to the NHS. And Royal College of General Practice has been repeatedly calling for NHS really and government to have a look at what we ask general practice to do, and some of our flow through the system, which actually is deeply frustrating for patients, deeply frustrating for staff, and bad for the taxpayer. So that's all good. You do slightly come back to, again, this, there is a bit of a tension in some of the to the local versus national, and I think, to use a very unfashionable term, of subsidiarity, if you remember back to debates about the EU. So one of the challenges that we've got is lots of bespoke local solutions to bits of DP, different hospitals, different practices, all coming up with the different things. That makes consistent flow really difficult. Same with social care. So as part of the challenge here is to work out, what do you do once and do you do consistently, which just frees up. And Mary Dixon, our lovely Mary Dixon Woods at this institute, points out that this is not just admin, there are safety things here. You know, when everyone uses very critically the different colour coding for different types of bloods and things in every different hospital, that's unsafe. As staff move around. So it's that subsidiarity point that I think we need to think about, doing the things that we need to do nationally well once, and doing the things that are best done locally well in each locality. And sometimes you think we've almost got the reverse, haven't we? We've got the stuff you should be doing locally going on nationally, the stuff you should be doing nationally, like coherent IT programs, being done locally.
Yes, and presumably, Bex, the PCNs is an opportunity to be able to have more interoperability, or at least some chance of efficiency in some of the admin. And also, I guess some of the ICSs are joining, aren't they, with hospitals to have a more of a joint electronic record that can help, and maybe similarly with admin IT, without getting down the rabbit hole of admin and automation. Surely there's massive scope there that can reduce frictions for GPs and clinical staff.
Yeah, I think there is. I mean, I was talking to a group of GP trainees this time last week, and I asked them what the single biggest change though for them was in terms of tech in the last year, and they said the ability to text patients. So there's all sorts of, sometimes the things that are seemingly small are actually the thing. It was an almost unanimous kind of response. And interoperability is, I can now see into the hospital record of my patients, and that is a game changer for me in practice. But there is a much bigger point beyond this, which is that these changes, and I would put estates in there as well, because we know that estates in primary care are woefully inadequate as they are, let alone to deal with an expanded group of staff. And we joke about putting people in broom cupboards, but honestly, it's not a joke for a world-class health system. Is if we are going to have a big transformation program in IT, and if we are going to have estates that are fit for the purpose we'll need to serve, then how are we going to do that? And I think Claire Fuller gets at this in her report, but we are all waiting with interest to see what the implementation plan is going to look like. And crucially, it's going to require funding, isn't it? So I think there is a lot of potential, but it will require investment, and it will require proper transformation support. And I think that is something that ICSs have the ability to deliver and develop, because it's back to that point I made in my first remarks. General practice at the moment is often still operating in relatively small units and will require an enormous amount of support to be able to develop in some of the ways we're talking about.
Yeah, just to say I completely agree with that. And the Confed did a survey a few weeks ago and found that across the system, but in primary care in particular, the issue of estates, equipment, capital investment is huge.
Yeah. So on that, I mean, there's quite a lot of questions about, what is going to be the shape of primary care itself, given the opportunities of AI and assisted decision making, which might allow then some of the role development that Anita was talking about, and allow other staff to make decisions safely, given AI support. So where are the sort of hope, the sort of game-changing hope on the technology side that could help? I mean, in the longer term now, which I think that you're seeing, where would you point to? Or is there no immediate game changer, but actually we just have to be faster at iterative development over the system? Maybe, yeah, who'd like to have a go at that one?
Well, I'll kick off very briefly. I mean, I think, with due recognition of the dangers that look, there is always a danger if you empower people, you have systems that empower people, that you generate greater inequalities, because those people who start with the greatest resources in terms of self-confidence, I mean, anything from self-confidence to Wi-Fi, can most exploit that. Yeah, it seems to me that the future has to be a future in which we seek to empower people to have much greater control over their health, to be able to monitor their health to in a whole variety of ways, to shift the relationship to one that is much more equitable between clinicians and patients and citizens. And I think in many ways that's the kind of meta challenge for the health service, is how do we get to that world of much greater patient empowerment in a way that doesn't exacerbate health inequalities. And that is a future that is potentially incredibly exciting. And I think that there are a whole number of important shifts in the health service which actually are based upon an assumption of a richer relationship, more reciprocal, more equal relationship between clinicians and patients. And I just don't think we're having the conversation about it that we ought to be having. So if you talk about, for example, virtual care, virtual wards, if you think about patient-initiated follow-up, if you think about anticipatory care, now these are all models that I support, but they're models that actually require a certain transfer of risk onto patients, but in exchange for patients having more control. Right? I mean, PIFU is a good example of this. You won't get a mandatory follow-up, so there's a slightly greater risk that you'll have a problem and no one will notice it. But on the other hand, if you do have a problem, you can access services with, the guarantee is you can access services when you need to. You won't have to go through a gatekeeper. Now that's a great idea, in my view. It's transformational, but it requires a different kind of relationship. And our politicians, what are politicians for? One of the things politicians should be for is having public conversations which make it easier for the clinicians to come in on the back of that conversation and say, you've been hearing about this new way of doing things and this new model. Well, actually, we're doing this in our surgery or whatever. Unfortunately, that's not happening at all at the moment.
Yeah, it does require quite a lot of confidence and health literacy, doesn't it, on behalf of the population, which may not be evenly distributed, as you say. But the question, I guess, is how you move forwards, and is it acceptable then to have vanguard areas where you would really trial the future in this way and hope that it would filter down? I don't know. Bex?
Yeah, I mean, just to respond directly to that point, Jennifer, I also think that there is an even more upstream point than that, which is around how we develop equity. Like, if we are developing products for the market commercially, those products often won't cater to those who have experienced the most barriers in accessing services are already the most served. So there's a systems issue, I think, around how we enable equity developed tech.
Bex, can I just come in on that? Because I agree with you, but I do agree with you, but I want to say we must always compare with what we've got, not with the perfect world. So when we talk about the impact of technology on equity, our concerns must be framed by where we're starting from. And actually, it's not, let's not compare the possible with the perfect. Let's compare the possible with what we've got now, is all I would say.
Yeah, I certainly don't disagree, Matthew. And I think there are examples of health tech incubators for equity popping up around the world. And I'm sure the NHS will start to develop that. I think just to bring it back to general practice, I'm going to say a very GP thing here.
Yeah.
I think that people care about how you make them feel. And it was very interesting to me to look at the GP patient satisfaction survey results last week, which do show that overall satisfaction has decreased. But actually, if you break it down a little bit, satisfaction with access to general practice has really decreased quite a lot. Satisfaction with the care you get once you are being seen in general practice still remains remarkably high, in the 90% on all of the markers. And so I think that part of the conversation about tech is actually about let's work out where the real challenges are. And I think one of the real challenges we have is around access. People are clearly saying that they don't feel that they're getting good access to general practice. So is there a role that tech and AI can play in that? Part of it will be in self-management. Part of it will be, do you actually need to access, this service? Is this the right one for you? I think that's really important because we have to demand manage in this context. But I think there's going to be another bit that is around how can we improve people's experience of accessing. And the final point, just on my touchy-feely general practice, how we make you feel, is that continuity of care is going to be still so important. People who have watched the recent Health Select Committee inquiry will have seen that continuity and the evidence for continuity of care has come up time and time again. It saves lives, it saves money, it is a good thing to do, and we need to work out which patients need continuity of care. So I think part of the conversation about tech and AI is also working out where we can effectively deploy it. And we have touch screens in our practice for checking in, but I watch the patients walk past them and go to the receptionist and join the queue. And there is an element of the human part of delivering healthcare that has to not be lost from the conversation.
Yes, I mean, if you think of a future where we are all a little bit more tech-enabled with general practice, and in order to transact more efficiently, quicker, at our convenience, there is the relational issue. There's a number of questions about this here, and actually a lot of GPs say that it's the whole patient, isn't it, that they want to treat. And if technology encroaches on that, which it will, I guess, at the patient's desire, are we talking about general practice, that element of general practice shrinking, or what will happen to it? Is it a paternalistic way of thinking about care in the community that has really had its day? Do we have to have general practice practitioners looking at the whole patient?
Doesn't it depend, Jeff, on the patient and on what their needs are? I think that's what Claire's got right. I think Bex's point is absolutely right. The danger at the beginning of the Fuller process, I think, was that we thought continuity of care only mattered to people with long-term multiple conditions. And I think that one of the things that Claire heard a lot was that continuity of care matters for all sorts of other reasons as well. So we can't have a simple world where we say these people need continuity of care. The rest of us, the kind of worried, well, I know people don't like that phrase, but you know what I mean? We don't. We just want a diagnostic test. And it turns out that the world is more complicated than that. But the fact that the world is more complicated than that does not mean that there isn't genuinely a difference between me wanting to know whether or not I should be worried about my mole versus somebody who's got several conditions and where the issue is really about how do you have quality of life given those underlying conditions. So again, let's avoid false dichotomies here. It's not helpful to imagine you can split up patient groups into those who do and don't. On the other hand, there clearly are very different kind of things that people want from primary care, and we almost certainly could be better at signing.
Yeah, I think the other thing that we need to think about is not it's either digital or it's this, totally personal human interaction. One of the things that we can use digital to do, if we got it right, is to help ensure that the time we've got in the human interaction is spent on the meaningful human interaction rather than essentially doing the processing that tech could do. Because a lot of the time when people are also, and GPs are frustrated because they encounter that the human encounter was dominated by sorting out administrative stuff rather than actually that really meaningful understanding of what is it's important to me, what's going on. Yeah, and the GP really trying to have the time to understand well, what is really going on and what's underneath this here? Whereas everyone's trying to work out, well, actually, I can't find the test results and I'm not sure. And the patient say, well, I'm not sure. I think that I've got my appointment for the outpatient before I've got my scan. Could you please sort that out, doctor? You know, the amount of encounter which is in low value added activity is also part of what makes a job unsatisfying and affects patient experience as well.
Yes, I just want to point people to a really interesting book written, I think, in 2017, something like that, on the future of professions, and it was how technology was going to affect it by Daniel and Richard Susskind. And what they basically said, paraphrasing, is that increasing technology would be able to hand a lot of clinical processes, if you like, in medicine to non-clinical, less clinically qualified people safely through AI and decision making. And actually the medics were left to dealing with the things that could not be protocolized, more complex issues. And so they almost argued that medicine would become, as it was, more of a craft in future, because it was murkier, it was less protocolized, because that could be dealt with elsewhere. So, you know, there is bound to be a role, isn't there, for clinicians in future to see the whole patient in those less protocolizable areas because of the, you know, more complex cases, for example. So I think rest assured there will be a role for GPs, I think, is what I'm trying to argue rather long-windedly. Good. We've got only 3 minutes, I think, or so to go. I think maybe just a little bit from each of you, probably 30 seconds, I guess, otherwise we'll run out of time. Just on, we know the screechingly awful red dials, where you think the hope is for the next, over the next 10 years, where would you begin with your solutions to some of the issues that Anita set out in the, I know that's a big question, but just a few things on the headlines where you think that we really need to trial something bigger or do something differently than we're not doing at the moment. So maybe I'll start off with Anita.
I think we've got to have, most people like working in teams, and the future of primary care is team. Yeah. And so actually, you know, if we get that right, that should make it more attractive to very many people, GPs and other professions. But it places enormous onus, as Beck said, on getting the move to teams implemented really well. And that requires a really good offer of support, probably an integrated care system level, to get that shift to work really effectively.
Thank you. Bex.
So I think that Matthew's point earlier about changing the conversation is absolutely critical, and pieces of work like this, I hope, are instrumental in helping to do that. So I get hope from the idea that the conversation will change, because it absolutely needs to. I also fundamentally think that general practice is a brilliant job, and patients and the public are fascinating, and there are intrinsic things to general practice that are fantastic, and we need to not lose sight of that. I co-founded a program called Next Gen GP a few years ago. We started with 60 people in a room thinking that was going to be that, and we've now had almost 3,000 early career GPs go through Next Gen programs. And so your answer to what gives me hope as well, it's also that there is a generation of people, and it's not just GPs, working in general practice who really, really do care. Yeah. And I think that is vital, because there are people willing to work with the problems that we have to develop a better system, and that's a good platform to start from.
Yes, and as someone said in a comment, patients also care a lot and would be willing to contribute to help with the solutions. Thank you. Matthew, last word to you.
Well, let me end with a positive story as well, which is I was speaking to an acute leader the other day who was expressing, as many acute leaders do, a certain amount of skepticism about the value added that ICSs could make to their lives, and complaining a little bit about ICSs getting involved in kind of performance management and second guessing. But then she said she'd been into an interview that morning and be on the panel for a primary care lead for the ICS, and that they had appointed somebody who was incredibly entrepreneurial, who didn't really want to run things, didn't really want to control things, but just wanted to start to change the conversation, exactly as Beck said, bringing people together, bringing primary care together, bringing the team together, bringing neighborhoods together, bringing community, acute, social, just saw their role as facilitating and enabling. Now, we have never created before public sector bodies of substance whose role is facilitating and enabling rather than being a kind of bureaucratic layer. And so from the Confed's point of view, supporting and challenging ICSs to be very different kinds of organizations and replicated at place level, which are about enabling, facilitating systems to work, and therefore viewing primary care as a system challenge, that's what gives me hope.
That's a great note to end on. Thank you very much to all our speakers, Bex, Matthew, Anita. Thank you all for watching and for your terrific questions. The slides and the recording will be available, so please check it out. And as I said, share with your friends. And you can sign up to receive any updates to future webinars if you like this one. So have a look at the link that will be put on the chat in a moment. So many thanks, and goodbye from us, and don't forget more on those tonight at 8 p.m. Thank you so much. Bye.